was still very weak, even according to their own official advisors. The UK government review that was conducted, we were promised a substantial evidence-based review that came out shortly after our little report, said that they had all of the evidence. And when you read it, it's couched in terms of the political and the economic case, not the evidence. The Hazards Campaign Review picked up at least 12 relevant papers to social distancing that was simply not mentioned in the UK review. Now, the bog standard thing for looking at what the evidence is would be a big meta-analysis, looking at loads and loads of studies. You don't have loads and loads of studies, you do a systematic review. It means you carefully go through all of the papers that are there and explain what is or is not significant. And you might just do a rapid review if you've got limited time, but of course they'd had lots of time by this stage to do a review. And what we actually got was something that was far short of a rapid review. So they ignored evidence that indicated that there was a problem. And the Scottish government basically followed suit. Now, Scotland tends to have been be much better and have been much better in its decision making. But in this respect, it just followed the UK government lead. And at the time, we had scientific evidence of varying forms, from lab-based studies right through to clinical cases, plus some cluster analysis, some sentinel events, and so on, from a whole range of sectors in the workplace that indicated the dangers of reducing the 2-metre mark. And SAGE said, well, you can actually reduce it because you can take mitigation measures. And they came up with 39 actions that were required to effectively mitigate reducing the 2-metre rule or 2-metre guidance, which shows you how dodgy it was. And at the same time, SAGE was saying that risks increased by 2 to 10 times at 1 metre over 2 metres exposure. So I think it was very dodgy, although it may have been partly supported by a flawed WHO assessment that was arguing for that, and that the Hazards magazine has effectively demolished the science on that. I don't think stands up. So the fourth thing to look at then would be what we know now from a Great Britain perspective, with continuing to work through the lockdown, which a lot of workers did, and the returns to work that have gone on since then. And what we can see is, for various reasons, including the lack of social distancing, the dropping to 1 metre plus has led to an increase in COVID cases. And whilst this was going on, there were 241 scientists in a respected peer-reviewed journal producing a statement saying the evidence was not only that we should keep 2 metres, but in a whole series of circumstances, it should be significantly higher because the virus could spread at least 7 metres in some instances. So we had the change, and behavioural scientists on iSAGE and on SAGE as well as iSAGE were actually saying, well, if you reduce to 1 metre, effectively you're ending physical distancing altogether. So they've got evidence from their own advisors. There was independent research evidence. This has now come out. The ILO support the position of 2 metres, and a whole range of countries do as well. So we didn't get a proper balance there between the public health and the economic arguments. Politics actually trumped all and has then damaged the economy locally, and I think we'd be saying nationally. So it's not a case of saying we don't want people to go back to work. We don't want the economy to get going. We actually want it to get going in a sustainable way by taking the appropriate precautions. So that's the fourth point. The final point, what should we do about it? I think it's fairly clear that in individual workplaces and in sectors, we should still be arguing for continued action to support the 2 metre distance. And that's where the safety reps and roving reps are going to be so important, because we know that there are workplaces where the sort of controls are going to be extremely poor. And we've got the evidence from both the physics and the behavioural science to support that position. We've got those sentinel events, and we've got clinical studies in a range of settings, particularly in the healthcare setting, but not only that, that indicates why we need to have this precautionary approach and keep the 2 meters. I think what's going to be important then is that the safety reps and reps are demanding the information from employers, from the public health bodies when clusters occur, from the local authority and from the health and safety executive. And we want, I think, analyses of where, I mean, today, we've actually got another big workplace cluster in Scotland in an abattoir. No surprises there. What we want to be doing is informing workers about what has gone wrong in these workplaces across sectors as well as individual workplaces. And we can't actually see that at the moment. So there may be strong arguments for reps collecting their own data, monitoring their own workplace to see what is or isn't working, what the problems are at 1 meter and 1 meter plus. And in that context, I think then, Janet referred to the Ice Age and the Hazards Campaign Charter. What we should be doing is getting that charter adopted and adopted by individual employers. And we need to be pressing for more inspection and oversight and monitoring by the various local authority and central government regulators to ensure that the appropriate social distancing is in place. Just finish by saying the Scottish Government still has as its default position 2 meters, don't go back to work if you don't think it's safe, work at home if you possibly can. So probably the practice of Scotland has been rather better on keeping 2 meters than in the UK where it's 1 meter plus. Okay, thanks.
Thank you very much, Andy. I'm very sorry about not having the slides up when you were speaking, but we'll make sure that those are circulated afterwards. But I think, you know, it's absolutely imperative that we ensure in our workplaces that we have that social distancing, that physical distancing in place while the transmission rate is so high, you know, and that's, you know, sort of fundamental, I think, to safe workplaces. But what is interesting is the number of workers that haven't gone back to work, that are still keeping safe in their own houses where they can, and the pressure that's coming to bear on them from government and from any authorities to try and get them back into workplaces so they could be spending money in city centres. And that's not about keeping you safe. It's certainly about spending money and about the economy. But thanks, Andy. That's a really good start to the session. Our next speaker is contacted me a couple of weeks ago, concerned at the lack of response in the movement following the increased knowledge and data about aerosols and airborne transmissions. And Jonathan, hopefully we've got your slides to help you, and I'll have a go at doing it again. Just give me a shout if it doesn't work. Make sure you unmute yourself, Jonathan, please, if you can.
Great. Thanks very much, Janet, and thanks so much for inviting us to this meeting. Just to say how appreciative we are of the work that the Hazards Campaign is doing. I think you're doing a great job in putting out the essential information for the trade union movement and indeed wider society. And also just like to mention my colleague John Dale, who's here with us tonight, also from Doctors in Unite, and I hope that this is the start of a fruitful ongoing relationship between our two organizations. Okay, so I think the audience tonight is quite knowledgeable, so I'm going to whiz through some of the slides. If there are any questions, obviously we can come back to them. Okay, next one, please, Janet. Many of you might have seen this. These are taken directly from the Independent SAGE briefing last week, just to set the scene. So death rates are very low at the moment. Fortunately, that's really good news. I mean, we can talk a bit about that if we have time, why that may be. Next one. That's hospital admissions, also at a low level. Leveling off though, not going down anymore. And next one. And that's now a number of confirmed daily cases. And you can see there that there has been an increase, and that is worrying. So the death rates don't actually reflect the increase in cases, because back in the terrible days of early April, late March, that kind of number of cases would be many more deaths. But as I say, if there's time, we can come on to that. Okay, next slide, please. All right, so as you all probably know, the three methods of transmission of COVID-19 are aerosols, direct contact, and droplet spread. And unfortunately, WHO, Public Health England, and the CDC in America still persist in their official guidance of failing to recognize aerosol spread. And we can come back to that too. But it seems pretty clear now that that debate is done and dusted. And I think there's a lot of work going forward about people simply accepting that that's the case and moving on and seeing how we can best tackle it. Okay, next one. So there's the basic diagram. This was prepared 2 or 3 months ago, so it's a little bit out of date. As you all know, it's not only about 2 meters social distancing. Aerosols travel much further, documented up to 7, 8 meters, and probably even further if the indoor environmental and airflow conditions are right. Just to say, COVID-19 is an indoor disease. Overwhelmingly, the outbreaks are occurring indoors. There have been some documented outbreaks outdoors and some super spreading events outdoors, but it's an indoor disease, and it's very worrying that because we're heading into the autumn and the winter, and we're all going to go back indoors. So that's going to be very challenging. Okay, next one. This is an important slide because it talks about the particle size of the droplets. Now, you may know that the virus itself does not survive naked in the air. It has to be contained in liquid droplets of respiratory fluid. The screen's playing up a bit, but the bottom two are showing that with different respiratory effort, the amount of droplets as opposed to aerosols changes. But it looks like, from what the aerosol scientists are saying, is that overwhelmingly the emission from expired breath is mostly aerosolized virus. The top diagram indicates where in the respiratory tract the different size particles will deposit. So if they're quite large, it'll be in the trachea and the bigger airways, and the smaller you go down to 10, 5, and even 1 micron, it will be in the alveoli, the little air sacs in the lungs. And that's bad news because the defenses of the lining membrane deep down in the lungs are not as good as higher up. So another reason why aerosols are dangerous. Okay, next slide, please. Well-documented outbreak in the restaurant in Guangzhou, that I'm sure you all, or many of you are familiar with. Airflow was right to left, and the tables were 1 meter apart, which is official advice about what should happen in restaurants. So I'm sure many of you, like me, will not go into an indoor restaurant or a pub, and this shows clearly why. Okay, next slide. This is about the documented outbreak in the choir in Washington back in early March, which again is quite well documented. A dreadful super spreading event where 53 out of 61 people in the choir practice got infected, 2 people died, and they spent about 2.5 hours in the same hall. The social distancing wasn't great, but it's quite clear from detailed subsequent analysis that aerosol spread was largely responsible for this. Okay, next one. Again, another well-documented outbreak. This is in a call center in Seoul in South Korea. The blue chairs are where people got infected. 94 out of 216 people on the same floor of the building got infected over a period of about 5 days. Interestingly, there was very little transmission on other floors, and clearly the workers on this 11th floor, I think it was, used the lift to get up and down. There's a lot of concern about lifts, but they're probably not as risky as we fear, because the contact time is short in the lift. You know, even if you go to the top of a building, it's probably 2 or 3 minutes. And we know that infection is related not only to viral load, but contact time in the environment of the person who's infected. Okay, next one. This is a graph of the case outbreak dates for that sole outbreak in the call center. You can see they are all over a period of 3 or 4 days. These are actually symptom dates. Testing took place a few days later, but confirmed the same sort of outbreak. And it's the typical super spreader picture of an outbreak. Next slide, please. Coming closer to home, this is the Greencore outbreak in Northampton. And again, the absolutely typical pattern of outbreak, sudden jump in cases of almost, I think, 250 over a period of 3 days. In fact, the total was a bit higher. With a steady low-level outbreak in the community before that. So clearly what happened, you had 1 or 2 workers going into the factory, and airborne spread, as we'll show in the next few slides, propagated spread throughout the factory floor. Next one, please. So that's a picture from Greencore. Don't know if this is the exact area in the factory where it happened, but as you can see, lots of workers, same enclosed space, no windows that we can see. I think the windows in the picture are all internal windows into corridors. We don't know anything about the ventilation rate or whether the ventilation system has filters in it, but very few of the workers are wearing masks, and there are a lot of people in the same enclosed space. So all the red flags are flying, if you like, in that photograph. Okay, next one. Now, this is a graphic from the study, the very well written up study of the Tönnies outbreak in Germany in June. The graphic at the top shows at the bottom left corner, the red square is the index case of that outbreak. The first part of the outbreak, I think 29 out of 147 workers were infected over a period of about 3 days. And you can see that there's an 8-meter radius of where workers were infected. 60% of workers who were within an 8-meter radius were infected by that one worker. Next slide, please. Actually, what happened, there was a second outbreak following that, because by the time they'd quarantined the workers from the first outbreak, they'd had contact with other workers in the whole complex. It's an enormous meat packing plant, this. And over 1,500 workers got infected, and it led to a lockdown of a large province, really, in Western Germany. And there was a lot of concern about it, obviously. Now, this slide's important, this one that's showing now, because there's a narrative that's evolved, which is pointing to workers as being the source and the cause of outbreaks. And this is a very important finding in the Tönnies meat plant study. And it shows quite clearly that they looked at shared accommodation and shared transport to the workplace. Now, sorry, it's a little bit technical, the graph, but effectively that dotted line, anything above it is statistically significant and below it is not. And the turquoise big circle at the top shows the outbreak within the factory. And all the other circles are of smaller collections of cases within accommodation and so on. But the conclusion of the authors was that the data strongly suggests that the transmission took place within the factory. Next slide, please. So what happens if you don't know about airborne spread, or you ignore the evidence of it, or official guidance fails to recognize it? That's a quote from the Director of Public Health in Northampton. And it's very poor. Her position is totally untenable. Basically, what she was saying is praising the company for doing everything right, and then turning on the workers and saying they congregated in car sharing, smoke breaks, and in shared accommodation, and then brought the infection back into the factory. That's completely wrong from not only from the standpoint of airborne spread, but also from the basic principles of epidemiology. You would have had to have a great number of infections out in the community to bring that many infections into the factory itself. And therefore, there would have been a lot more transmission in the community from different households and so on. And in fact, the Joint Biosecurity Center that's been recently established itself said the outbreak was entirely located or entirely related to the factory itself and not community spread. But this is important because what happens here is that the narrative then points the finger at workers to be blamed. And that gives ammunition to reactionary politicians and right-wing forces within society to engage in racist stigmatizing and scapegoating of workers. And it often is poorly paid migrant workers who work in these factories. And so the science is actually very important to defend workers against these completely unjustified attacks. Next slide, please. Okay, so what can we do about it? I think some of the posts in the chat, I think, are very helpful and relevant, but very quickly to go through here. Air exchange is important in terms of ventilation. Carbon dioxide can be used as a proxy measure for adequacy of ventilation, and air filtration is important because you can actually get rid of the virus with quite old technology, simple HEPA filters, which work quite well. But the actual specification, size of the room, airflow, etc., is important. I've put on the slide there, I'm quite happy to share the slides with people if they want them. Some of what I call the gurus of aerosol science on Twitter. So if you'd like to have a look at them, they really are very knowledgeable and always happy to share their knowledge and engage with you should you wish to talk to them on Twitter. Okay, next slide, please. Actually, John Dale came up with this, and we've put this in the document about what we should be doing and saying to trade unions what they should ask for. It's basically a recognition of airborne spread. Ventilation needs to be looked at. Trade union supervision and control of workplace safety is important. Surveillance testing of workers so we can nip these things in the bud before they spread. And I'm sorry, I can't see the last point. Anyway, you can have a look at that later. Next one, please. Okay, masks are important, they work, okay? And what the experts say is that on average, fitting of masks is about a 50% reduction in exhaled production of virus, about a 30% reduction in inhaled virus. So you can see if two people in the same space wear a mask, already you've reduced the amount of virus in the air by about 2/3. If the fit is better, the protection is even better. Don't take your mask off to talk to people. That's exactly the time you need to keep it on because you produce more virus when you talk. And this nonsense in government guidance that says when you're indoors and you can't socially distance, that's when you should wear your mask. You should wear your mask all the time indoors. As we've seen, aerosols can travel much further than 2 meters. So any indoor space is potentially risky. So again, I don't go to the pub and I don't go to any indoor restaurants. So what individuals can do themselves, that's a list of things to do. Open the windows in any public transport, in cabs and things like that. Avoid people that are being loud because shouting, singing, etc. is bad news. Keep your encounter time to a short period of time. Next slide, please. Just some pretty pictures of people wearing masks. Next one. This is a useful graphic from a recent article in the BMJ, which basically sets out the conditions of risk. In short, the more indoors you are, the less the ventilation is, the more people that there are, the longer you spend in indoor spaces, the greater your risk. Next one, please. And that's a very similar thing. As you can see, the green is outdoors, pretty safe unless somebody's literally in your face, down to, exercising in a gym is probably the worst thing you can do, with heavy breathing, with poor ventilation. And on the right-hand side, those are all the factors of risky activities and so on. Again, time spent, size of the space, ventilation. Next one, please. Remember, surface spread is still a risk, so it is important to wash your hands. And we all touch our faces very, very often. There's an interesting video where they videoed a class of medical students, and on average, they touch their faces 23 times an hour. So we all do it far too much. Next slide, please. That's it. Good. Okay, that's it. Thanks very much.
Thank you very much, Jonathan. That was really interesting. I think, this narrative about praising employers, and the companies that are exposing workers to the virus is coming out constantly in a number of different workplaces where they've had outbreaks, and this it's all about the workers' fault, and I think that's where we're seeing that more and more. So that was brilliant. Thank you. So our last speaker this evening is Hilda, and Hilda is a phenomenon in terms of the knowledge that she has around health and safety, but has worked phenomenally, throughout this pandemic in trying to ensure that workers have got the support that they need to go in and challenge employers. So I'm just going to try and find Hilda's presentation for you.
Thank you.
Hopefully.
Fortunately, Andy and Jonathan have done a really, really good job and have produced much better PowerPoints than mine, which was a very, very quick job. I'm going to try not to repeat things that have already been said. I agree with everything that they both said, but I want to just sort of bring it all sort of back together again and remind everybody that health and safety law is still exactly the same as it was before COVID, and that is what must apply and what we must be ensuring our employers are applying. And that means starting with suitable and sufficient risk assessments of all the, based on all the known methods of infection and transmission of the virus, involving safety reps and workers, consulting them, and always using the precautionary principle, as Andy has very carefully laid out. And applying, using the safety reps and safety committees regulation rights that we have, and that we have to use them. Both Andy and Jonathan have made very clear. The HSE has gone completely AWOL. Workers are being blamed for this. The workplace is the source of infection and the site of spread of infection is being completely ignored. It really is the workplace stupid, and they are completely ignoring it and leaving workers at risk, but at the same time managing to blame workers, as is always. Blame the workers is the usual cry. The need for democratic oversight of employers' risk assessments and their mitigation and prevention strategies, challenging them at every turn, asking questions, keeping records, representing members, trying to make sure we can get the best possible health and safety is absolutely essential. Collective action is absolutely essential because there is nobody else there for us, and workers are having to do it on their own. And so following on from a proper risk assessment, obviously what we have to do is to impose the hierarchy of risk control, which is laid out very well there. I think that's a really good graphic showing the most effective collective measures at the top to the least effective individual ones at the bottom, and starting obviously with the elimination and substitution, working at home, avoiding people, avoiding the workplace, avoiding contact with other workers, with other people, and that's absolutely important. And to very much remind people that personal protective equipment is essential if on a risk assessment there are residual risks of infection that can't be controlled by any of the engineering or administrative controls or elimination, that then there must be proper personal protective equipment to protect workers. And this is different from the face coverings, which have been covered already, which are to protect other people from the wearer who may be asymptomatic or pre-symptomatic, but carrying the virus and breathing it out. And there may be a need for a combination of both of them, but it's very, very important that workers are very clear about the fact that there's a difference between those two things and the need for them when they're most appropriate. Thanks, Janet. Can we have the next one, please? Now, because Jonathan has done a lot of things, we all produce these without knowing what anybody's going to say. So a lot of what I've said, what I'd planned, not knowing what Jonathan would cover, is probably not very relevant. Just this slide is just very useful. It's from one of the people that Jonathan listed as being very important, is Lindsay, I've forgotten her other name now, in America, who's absolutely brilliant on all this sort of stuff. And she just makes the point that there's an unhelpful cut-off point between the big droplets and the small droplets. And the aerosols, as we call them, are usually defined as the under 5 microns, under 5 millionths of a meter, which can spread the very long distance, and the droplets are those over that level. But that's not such a useful way of looking at it. Next one, Janet. And as this is just very much what Jonathan said, and I'd just like to point out, in this graphic, because it shows the droplets falling to the ground, and that's very important. When things fall to the ground onto floors and they fall onto other surfaces, then they become a source of, the fomite route of transmission, and there has to be a lot of cleaning, and depending on the temperature and the humidity and whatever, there can be evaporation of those droplets, and then they can become resuspended and become, another hazard. Next one, Janet. The only reason for this one is really, I just want to add in, and Jonathan did mention this, is the extra sort of route of infection, which is the sort of fecal route. Virus can be passed out in the feces, and therefore toilets and flushing toilets can become a source of a fecal plume. Droplets and aerosols can become airborne and then be deposited on things and then be touched and transferred to the mouth. And there are also issues about cases where there has been transmission through the sewage and wastewater systems within buildings. Next one, Janet. And that's again just confirming really what Jonathan was saying. The slide on the left shows the situation without ventilation. The droplets obviously will drop out within the first 1.5 to 2 meters. The smaller, under 60 microns, will go further. And the slide on the left shows that that's what you're trying to filter out. That's what you're trying to get rid of by ventilation. Thanks very much. Next one, Janet. And so the route of viral ventilation is dilution, removal, and inactivation of the virus. And Jonathan's covered a lot of that, so I won't labour that. So you can go on to the next one. And again, just to reiterate and emphasise again what Jonathan was saying, and the importance of ventilation and of trying to really tackle the whole aerosol transmission, is that the very, very small particles are the ones, the pink ones in the diagram, which are getting to the bottom of the lungs, to the deepest part, to the alveolar region, and this is where they can do the most damage. And the more of them that get there, the more severe the infection is. So everything we can do to reduce those small particles, and as many of them as possible, from getting into people's lungs and getting to that deep, is actually really, really important. And that's what it's really all about. Thanks, Janet. Next one. Okay, again, Jonathan's covered all of this really. You can measure carbon dioxide levels as a proxy for ventilation, and really the experts, Lindsay Marr and the various other Shelley Miller and other people that he was talking about, they talk about a level between 60 parts per million and 600 and 800 parts per million as being equivalent to a well-ventilated room, and above that's a sign you've got a problem. And they talk about the optimal level as being about 6.7 litres of air per second per person. Obviously, the fewer people in a room, the more fresh air there is for those person at whatever level of ventilation. The more people there are, the more ventilation you're going to need, the more air changes per hour. And some people put 6 air changes an hour or higher, maybe 9. And Jonathan has talked about filtering the air, trying to get some of these particles out with high quality, high specification HEPA filters. And there's also the idea of disinfecting air intakes at source using ultraviolet light. Thanks, Janet. Next slide, thanks. I'm not going to go through this, but it is very important because the HSE has been absolutely pathetic on the whole issue of ventilation, to look for other sources of information that we can use to persuade public health and our own employers that they're not doing enough and that they need to do more. This is from the European Centre for Disease Prevention and Control, and it's there to be used, and it deals with all the ventilation issues. Do you want to, next slide, Janet? It goes through all the things that employers and building managers should be doing. Next one. And there's a summary of these, which the Federation of European Heating, Ventilation and Air Conditioning Associations has produced as to the things that employers should be doing and the questions that you can be asking. This is very important. PCS, we've got Tracy, their health and safety officer here tonight, Tracy Edwards. They took up the issue of ventilation with the HSE in June, and the HSE replied in July with very, very pathetic information that basically there should be good ventilation, but there wasn't any need not to have air conditioning, and there wasn't any need to sort of stop fans, despite the fact that some of the cases that Jonathan and Andy have referred to are show that there have been cases and there has been spread through air conditioning. There have been some recent cases. There's been a good case from a Dutch hospital where wards that had recirculated air through the air conditioning system, that's where they had the infections, and the wards where they were taking in fresh air without any recirculation, there wasn't any infection. So the HSE advice on this is absolutely rubbish, and these questions here and these suggestions as to what your employer should be doing are actually incredibly useful, and includes the issues around the toilets and the fecal plumes. There's a bit of an issue with this about instructing building occupants to flush toilets with closed lids. In quite a lot of places you don't have closed lids, and certainly for disabled toilets there aren't closed lids. So there are lots of questions and issues and things that safety reps have to use to challenge their employers. We are not experts on this. All the sort of things that we've all talked about, these are just to give you more information that you can then use to question and challenge your employer and hold them to account. Next one, Janet. And there are more, there's some very, very good, very, very detailed guides, which I think it's useful to look at. This is one from Harvard on how to measure ventilation rates in classrooms, which is not something that you would do yourself, but it is something that people could be insisting. I think it applies fairly well also to offices, and it's the sort of thing that you could use to make an argument to your employer about the poor rates of ventilation and what they should actually be doing. And it spells it out in a way that's fairly easy to understand, and the link to that is at the bottom, and it's in the resources at the end. Next one, Janet. Again, Jonathan's used this as the mask thing on the left. Masks do work, they are useful, but not all masks are the same. Some masks are better than others. There's just been a recent paper, which I've put underneath that diagram, which has got some fantastic videos on visualizing the droplet dispersal for face shields, for visors, and for masks with exhalation valves, showing the aerosols pouring out of them and the fact that they shouldn't actually be used. I think it's well worth using these sorts of things to make clear that you understand what's going on, and to use with your members and also with your employers. So, you know, not all masks are absolutely the same, and to keep in mind that the masks that prevent you from infecting others, obviously if we're all doing that, we're all having a mutual protective effect, but they're different from personal protective equipment, where that is a mask that protects you, the worker, and if that's needed, that's what you must have, not just a cloth mask. Next one, Janet. So what we're really looking at are layered multiple control measures. This is just a good graphic from Lindsay Marr showing no interventions, and it shows I don't know if you can see it very well, but there are big droplets and small droplets, and it shows them in the air and it shows them falling on the ground. It shows controlling the source, so having the person who's infected wearing the mask and what that does, and it shows what ventilation does on its own, and then distance and PPE, and then hygiene, and then all the interventions together. And that's a very good way of showing how we need all these interventions. There's no one magic bullet Nobody is saying that wearing masks are going to solve the whole problem, and that you don't need hygiene, you don't need to be washing floors and washing surfaces and washing hands, and that you don't need social distancing. You need all of them, and you especially need the ventilation and the filtration. Next one, Janet, please. And I had this slide as well that Jonathan's already used. I think it's a very, very useful slide to show, because many of our employers are coming up with risk assessments which really would win fiction prizes, and they're a load of old bollocks, and they hardly ever have anything that's a high risk. And I think you can see how very quickly high occupancy, poor ventilation, overcrowding, and a longer time doing anything, it actually increases the risk, and how it's actually impossible to do some sorts of things safely. And I think that's very important for us all to use that. Okay, that's really all I had to say, and there are a list of resources there, and I hope that was useful. Thanks.
That was excellent, Hilda. That was a really good summary of where we should be at. Just let me stop sharing now. Okay. So I mean, I think the interesting thing that you raised about face shields, I think, is really useful, because the number of meetings that I've attended on Zoom, where teachers are talking about the need, for people to be able to see their faces, and we're going to wear face shields. And when I went to Blackburn yesterday, a lot of the lecturers are all wearing face shields, and there's absolutely no protection for those individuals.
No, there's no protection either way. I mean, it's a risk both ways. It's a risk to the wearer, and it's a risk to other people. But I understand why people did it. I used to wear one, and I thought, because it was much better, and it's good for, if you're actually having to talk. But it's a problem. It's not actually going to work. And I think that paper is very good, with some brilliant videos showing exactly why that's not a good idea. And we still have problems. We still have problems with all of this. How are we going to do certain sorts of jobs? How are we going to teach? How are we going to communicate, wearing masks? And it still is the issue that I think we have a problem, that it's very hard for us to make workplaces COVID safe, to pretend that we can actually do that, when the infection rate in the general population is so high, because the government has done bugger all in getting it down. And that's the really, really serious problem that we still have to tackle, as Andy has very carefully laid out, the overwhelming economic and political case just to force everybody back to work, and therefore for workers to take risks. And so we're going to have to be very, very firm on fighting that.
Yeah, thank you. Right, so we've got some time for questions. If anybody would like to ask a question in person, you'd like to put your hand up, and I'll try and bring you in. So Andrea, you'd written something? Got a question? Asked to unmute.
Yeah, sorry, I was pressing the wrong thing. Yeah, it's just really about the Green Corps in Northampton. So, I was really shocked when, you sort of reading what the head of Public Health England was saying there about blaming workers coming to work together in their cars and whatever. And I just wondered about whether it's unionised, and whether there's been, the unions have been able to kind of push back, and challenge that narrative. I've kind of that's not been reported, but I still think it's kind of important to be doing that, and I just wondered whether they've been able to.
I don't have any information on that. I think the Bakers Union were involved in that one. Jonathan, do you want to come in and answer? Yeah.
Yeah, we've tried to contact the local unions. In fact, John Dale, you might want to say something here. But absolutely, and there's also an organisation called Save Northampton Services, which put out a very good press release challenging this dreadful narrative from the DPH. And she had the cheek to say that the evidence indicates that it's the workers outside the factory, without producing any evidence. And that's really bad. But John, did you want to come in here?
John?
Well, I think there's somebody in the meeting from the Bakers Union, so they will probably be able to.
You've lost your sound.
Sorry. Yeah,
Oh, you've gone again.
Bakers Union.
Carol, do you know the answer to this?
But
Hi,
can
Carol
I just
Hillaby.
make another observation before
yeah, okay.
Carol comes in, and then I'll shut
All
up. The well-publicised workplace outbreaks mostly seem to be workplaces that are quite labour-intensive. The food processing, meat packing, the call centres in South Korea and here in the track and trace system as well, in the sort of the heart of the government's response. Hilda, maybe you know, or maybe Andy will be able to tell us if all of these outbreaks have been where there are many workers in a fairly small space, unlike, for example, a chemical factory or a warehouse where there's very few people actually on the premises and they're all spread out. I think that's significant and answers some of the points from the Northampton Public Health that is blaming workers. It's the environment that workers are in. And that comes back, of course, to the need for anybody who is either a case or a contact to be isolating on full pay and not on statutory sick pay, which is what has undoubtedly led to these spreading. Thank you.
Okay. Thanks, John. Just let me bring in Carol.
Hi, everybody. I'm not sort of up on what is actually going on with Green Corps because that's being dealt with by our union official, George Atwell. But I do know that the people that have tested positive have got a choice. They're either on statutory sick pay, you know, and they're trying to feed their families because the company will not give them sick pay. So, you know, they've got a choice. Do they still go to work so they can feed their family or do they self-isolate? So they're really having a lot of problems down there at Green Corps.
Yeah.
Yeah, thanks, Carol.
Definitely.
Yeah, Andy, do you want to come in?
You're mute, Andy. Mute.
Still on mute.
Mick will be on at me again.
There you are.
Yeah. What John was saying about evidence, I think is very important, and I think this runs through so many things that various statements are made, and Hilda was referring to it in terms of the risk assessment. But you get statements from the employers, and you get statements from the health and safety executive, and you get statements from the local authority, and you get statements from public health that simply aren't evidence-based. I think it's really important that reps actually ask for copies of the evidence that they say demonstrate that there aren't problems. I mean, we found this with cleaning activities, we found it with screening activities and so on. Manufacturers say, this is the information that they say it's safe and we've tested it, but you can't see the information. So that's one observation. And the other one from John, I think a number of studies have now identified both the sectors and the particular work groups that may be at risk. And I think what he says is generally true. I think in Bradford, there have been cases in some of the bed making companies, haven't there? And there are a few outliers there. But I think the conclusion you could draw from that is if we know that there are these industries that are particularly susceptible, then it should be possible for the health and safety executive and the local authorities not only to get in there now when clusters occur, but to be in there before the clusters occur and have a look at what's going wrong. So it's manageable. You know, one of the arguments is, well, the resources are limited, and yes, they are, and we need more. We need more people in the regulatory bodies. But if they had the focus on what we know are the high-risk areas, much more could be done. Yet time and again, it's not happening.
No. Thanks, Andy. Hilda, do you want to come in on that?
Nope.
No. Tracy, you've got your hand up to ask a question.
Thanks, Janet. Well, it was more a kind of a comment, really. It's really good to see the issue of airborne transmission being taken up by the Hazards campaign, because it's something that we've been raising for a while in PCS. And I think that what it comes down to really is that you know, there's all sorts of excuses from employers, and I think it's obviously very clear that the reason why that there's a kind of, you know, a denial of the existence of the airborne transmission route is because it's, you know, it costs money, doesn't it, to you know, look at air conditioning systems, which have posed a problem before the coronavirus, anyway, in terms of, you know, recycling of old air. We've got other issues as well in terms of in the civil service in the areas that I represent. There's been a lot of hot desking, for example, and then obviously, you know, that all brings into brings into the fore about the issue around hygiene, and then of course you know, the amount of cleaning staff and whether they have the appropriate PPE, and obviously as well sick pay. We've won quite a significant agreement with the Cabinet Office in PCS, and basically during the summer, as a result of PCS pressure, they actually agreed that all the contracts that they'd outsourced in the civil service, in terms of, you know, if they were still paying those contracts, that they must pay full sick pay for those members of staff. And it was a huge victory, and we're looking at extending our we're calling it a Dying for Sick Pay campaign, which is quite a good you know, a good title for it, into other areas. But one of the things that strikes me is that obviously, you know, we know that there's been confusing information or lack of information that's come out from government. It's been biased. The role of the health and safety executive obviously has been shoddy. Really, you know, we're going into the autumn, going into the winter, and the point was made that there's going to be more people who are going to be working indoors. But I think for the majority of workers in this country, it's not understood really about this, and it's about us thinking as a movement about how we can start to kind of get this information more widely out into the public domain. I mean, I think that we should, you know, the Hazards campaign, for example, could play a key role in contacting all the major trade unions, and specifically for us to be campaigning on this issue in particular. And we should have a cross-union campaign, getting this actually recognised, you know, properly. One of the things that worries me about masks, and I think obviously they have been shown to be kind of effective in terms of it obviously reduces the amounts of droplets that are emitted from people who are infected. But what I worry about now is that the fact that because there's a lack of clarity and a lack of information, you're seeing social distancing going out the window. I mean, I went down to my local co-op just the other day, and you know, before they had the kind of 10 people in, queue out system, but now you go in and some people aren't wearing masks, but now you go in and it's just the same kind of full capacity. So I think, you know, throughout the labour and trade union movement, this issue in particular needs urgent attention in terms of getting that widely out there. And I think that the way that Hilda presented it in her presentation could be something that we should be rolling out across the country. And I've also written to you, Hilda, to invite you along to our health and safety reps meeting on Tuesday, which I hope you can attend. But I'd be up for, you know, discussing with anybody about how we can build a campaign around this to get it more widely out there, because at the moment, you know, it's just workers being blamed for it, and you know, it's not because we're going to the pub or because we're going to the park, and it's you know, it's going to result in further deaths. So thanks.
Thanks, Tracy. Hilda, do you want to come back on some of that?
Yeah, I mean, I think the problem is that before COVID, we had all these problems with workers going to work when they were sick because they couldn't afford to stay home, and COVID has just made that much more clear and much more unjust and much more of a problem, because it's a threat to more people, and that's something we have to fight against. And the issues about ventilation and about needing good ventilation to prevent COVID. Most of our workplaces where we have lots of people working indoors have absolutely crap ventilation and have had for bloody years, you know, and issues around hot desking and things like that. So we've actually got this legacy of crap health and safety that now just actually, you know, is exacerbated by the pandemic, and that we have to sort of tackle together. And I think we have to use all of this in a much more concerted way, you know, and it isn't just about, oh, we'll do this now, you know, we'll have sick pay now because of COVID, or we'll banish hot desking because people are touching desks. Those were problems anyway, and they're just made clear by this. So I think we have to be, you know, very systematic and use it to get rid of all this bloody thing and try and get better ventilation. I mean, I think if we tested the ventilation in most indoor offices, loads of other indoor workplaces, and particularly in schools and universities, they'd be shut down right away. You know, the levels of carbon dioxide would be absolutely bloody off the roof. And so I think we have to try and, that's why I try and place it in you know, the Hazards Campaign tries to place this all, you know, within the context of, you know, the whole of health and safety, and a systematic approach to it all.
Thanks, Hilda. Jonathan, you wanted to come back?
Yeah, no, I think it's a great idea, and I think the trade union movement must take it up. And, you know, if Francis O'Grady said something about how important ventilation is, I think it would transform the national debate. The thing is getting her attention and her buy-in. But I just wanted to raise another point, and that is about the official PHE guidance. And now that PHE has been axed, we don't know where the hell we are with these things. But official guidance still says there are only two routes of transmission: droplet spread and contact. And it actually excludes aerosols, or concedes aerosols only in certain medical procedures which are done in hospitals. Now, the problem is not only is that the case, but the pushback that we find we're getting is when you raise it in the workplace or in the classroom and so on, employers come back and they say, that's not in the guidance. And so it's very important that the publicity material we put out makes this point very forcefully, that the guidance is not fit for purpose. And this is why the hundreds of aerosol scientists wrote to WHO, why there's a whole campaign about it. And medico-legally or in trade union legislation and health and safety and so on, we all know that the courts will decide on cases based on what the official guidance is. And we see this time and again with medico-legal cases. The judge will decide a case according to what the guidance is and whether the guidance has been followed. So if official guidance does not talk about ventilation, then we are deprived of a very important tool or support in terms of making cases. So I think it's crucial that within our publicity material, we really expose the complete inadequacy of current guidance and call for it to be changed. Thanks.
Thanks, Jonathan. Hilda, you wanted to come back?
I don't want to cut across Andy unless you want to take this, Andy. Do you want to say something there? Sorry,
Can't hear you, Andy.
Muted.
Still muted.
Oh, okay. I think that's absolutely right. But we have right from the beginning made the point that the government guidance on COVID is not right, and that it actually breaches the Health and Safety at Work Act and a lot of basic health and safety legislation. And we have made clear that even the HSE guidance doesn't do that, and it's not statutory. So that's why we are basing a lot of what we say and say that, you know, health and safety at work, the health and safety at work regulations and everything that goes under them is what actually counts and what we should be going back to. And COVID is just a particular hazard sort of under that. And that's what we have to go back to. And that's really, you know, but that is something we have to hammer home and keep on hammering home. You're right.
Thank you. Andy. You've got on mute.
Yeah, just a little point. There are differences across the three nations. And I think it's worth sometimes reps being able to draw on different approaches. So yesterday, the day before, one of the chief advisors to the First Minister in the COVID briefing specifically started talking about aerosols as a route of transmission. So there is some recognition there. Whether that then, as Jonathan says, is reflected in the guidance, and for us it would be through Public Health Scotland and Health Protection Scotland, is another matter. And linked to that, of course, again in Scotland, there is an acceptance about the Fair Work agenda, about involving trade unions far more, and Kathy Jenkins has been heavily involved with this, so she knows all about that more than I do. But also in that context as well, we've got the roving reps and a recognition that in certain circumstances where there are non-unionised workplaces, then you could have trade union roving reps going in. So there may be things in the 3 different countries in Great Britain that will mean that it's possible to make arguments with your own workplace and possibly with your government, you know, about what should or shouldn't happen. I'm not holding up much hope of that happening in England, but it might possibly in Wales.
I think that's a good point, Andy. I think that's it. It's really useful to be able to use those differences to perhaps put pressure on our employers, even if the governments aren't going to come out and support us. Kendrick, you wanted to speak. Do you want to unmute yourself?
It's just if someone refuses to enter a workplace or leaves a workplace.
Sorry, can you just repeat that, Kendrick?
So if somebody leaves a workplace or refuses to enter a workplace because it's not adhering to social distancing,
yeah,
are they protected under Section 44 of the Health and Safety Act? Thanks.
Okay, there's some difficulty with Section 44 of the Act, and you know you've got to use that in a collective way if you're going to use that. But nobody should be put in danger by going into work. You shouldn't be. You know, the control should be in place, and you know, really, what you should be doing is talking to the complaining to the HSE. You know, putting in the complaint to them, and you know, to stop being able to do that. It's difficult, isn't it? And really, we want to have collective responses to situations like that. But does anybody want to add anything to that? Hilda, did you indicate to add?
I think, yes, Janet's quite right that, you know, Section 44 of the Employment Rights Act gives you that protection, but it's actually very difficult to get it enforced, and you can still end up being sacked and then waiting a year or more for a tribunal and be out money. So it's actually not something you can use as a shield. You know, it's something that you use as an argument in a collective sense. I think that's the most important thing. But it is true that you should not be, you know, you do have the right to have a workplace free from risks to your health, safety and welfare. And I think that's something that we have to push much more. And that's one of the reasons why in our paper with the Independent Sage, you know, we argued for not leaving this up to employers who can't be trusted to do this right. They can't be trusted to even put in place the inadequate guidance that there is. And that's why we have argued for proper investment in, you know, the HSE and local authorities so that workplaces can be inspected. And Janet's right, though, you could actually make a complaint to whichever is the enforcing authority, the HSE or the local authority, that a workplace was not actually complying with this. Because this actually is now not just a health and safety issue, but in a local level, this is actually a public health issue, because this is possibly, you know, the start of another workplace outbreak and cluster that could end up affecting the community. So you're more likely to have it taken up by somebody, but it is important to do it. I think it's better to do that sort of thing. But if you can work together with your colleagues, then that would be even better as well.
Thank you. Phil, you wanted to speak?
Yes, what I've done, and I've said to my members, if you feel unsafe, you mention to the employer that you're not working in that area, you're not refusing to work, but you're not working in that area under Section 7 of the Health and Safety at Work Act. You're not going to put yourself or anyone else in danger due to the COVID. So if they find a safe alternative, you will continue your duties.
Yes.
Yeah, thanks.
That's a much
Phil.
better idea, Phil. Well done. Yeah.
Yeah. Any other questions? Don, you made a point about air quality impact assessments. Did you want to say anything more about that?
Yeah, well, in the past, I worked for social work, and I do many social work inspections and highlight the poor air quality. And I done a COVID workplace inspection a fortnight ago, and there was, in the room that I'm always highlighting, that there's normally 4 people working in it, without a window, with a small tiny air vent, about 6 inches in diameter. There was only 1 worker. So they're listening. But then I went into another room. There was 5 workers with no air quality whatsoever, with the fire door wedged open. And I said I was coming back out to inspect the building again under my other role. The other thing is I've been off work for 4 or nearly 5 months shielding, and I went back to work. The risk assessments employers are using are generic. They're not geared to the individual, which is not correct. So they're just doing whatever they want. The other thing is people in my workplace who have continued to work are working in an environment with children, 8 children, up to 5 workers, and 3 shift patterns. There is no social distancing whatsoever. And I told them I fear if there's an outbreak, it's going to be horrendous. But what do? You can't give up your job, especially, you know, I've just returned to my work. I can't wear a mask because I can't breathe. Find it very, very difficult if I wear a mask. And I was advised, you know, to go on the sick, but I don't think that's relevant either. You know what I mean? I'm getting to near retirement age. So, and there's many people in that position as well.
Okay, John, thank you. Can I just bring, is it Hunter Mar? I don't know what your name is, sorry.
Hi, it's Margaret Ann.
Hi, Margaret.
I'm a union rep in the healthcare settings in one of the boards in Scotland, and I'm a registered nurse actually. I wonder if particularly Jonathan would have any information with regards to the use of PPE in different settings. For example, in the intensive care areas, it's full PPE with FFP3 mask, respiratory masks, whereas in other general settings within acute hospital settings, it's the simple blue sort of fluid resistant masks, which are paper based really. And if you know of any research or evidence around the levels of contracting COVID in those probably more protected settings such as ITU as opposed to a general ward setting, and in terms of air exchange, what is actually required in a general ward setting where all you have is a few windows which don't really open very far. We have staff who are coming into close contact with patients who have COVID, and they are advised to wear plastic aprons with the blue masks, which I wonder, given the aerosol generating distances that you've described, might actually be a hazard to them. Just to see if you are aware of any research around any of that.
Okay, thanks, Margaret. So there's a couple of issues. There's quite a few issues that Don's raised and Margaret's raised. So Jonathan, do you want to come in first?
Yeah, sure. I think it's a great question. That there was a study which showed, as you've sort of indicated in your question, that the antibody positive rate of healthcare workers on general wards was higher than the workers in intensive care units. For the reason you said, because in ITUs it's a red zone, so everybody has full PPE, whereas the risk in general wards has not been recognised. And personally, I'm absolutely convinced that the very high nosocomial transmission rate, i.e. the high rates of transmission of COVID within hospitals between patients, which is about 20% at one point, it might be a bit lower now, is due in part, at least, to aerosol spread. one of our members in Doctors in Unite is actually, she's a junior doctor and quite concerned about her risk on the ward. It's very difficult because, look, to be fair to the government and employers, the economy was not engineered with COVID in mind. This is a new virus. But the head in the sand approach and just pretending it doesn't exist is serving no one. I've been in touch with Imperial College as well and raised it with one of the senior managers there, and he tells me that they are looking at it actively. What can be done is very difficult. I think my advice to you would be to raise it and ask what the hospital is doing. What is do they recognize aerosol spread? What are they doing about it? How are they trying to mitigate it? And I would push for the highest level of PPE you can in every setting. Healthcare is by definition a high-risk environment. And I think if I was in your situation, I would be trying to get the best quality PPE I could.
Thank you. Yes, Hilda, did you want to come in on any of those points?
Yes, but I don't want to just jump in front of Andy again, unless Andy wants to say something.
I was going to bring Andy in.
All right, okay. Yes, I'd echo what John said. There has been research showing that the people in ICU and in supposedly the most at-risk workplaces in healthcare are actually having the higher levels of PPE and are actually not suffering in the same way as workers further down. And that's backed up by the ONS research about deaths and the sort of people who are dying and getting ill within the health service, and that's a very serious issue. And that brings us back to to the point that everybody in healthcare, if there's a risk which you can show that there is a serious risk, then you're talking about proper personal protective equipment for those workers. The blue medical mask is not personal protective equipment. It's there to protect patients from you. And the HSE produced a research report 169, I think, a few years ago, which absolutely backs that up. They've conveniently forgotten that during this pandemic, but that you need to bring that out again. And the issue is workplace. The hospital is a workplace, and so the issue about what air changes and what ventilation there should be is the same as in other workplaces. It's got to be suitable and sufficient, and it's covered by some of the guidance and the regulations and the suggested air changes per hour and so on and so on. But also in a hospital, it's related to infection control. And how have we forgotten all the stuff that we ever knew about TB and how in hospitals TB cross-infection was actually prevented by having incredibly good ventilation. So I think we have to go back to, again, it's hard work, there's no magic bullet. It's about challenging and questioning and holding our employers to account. But there is masses of evidence to back you up. As Andy has just said, the stuff that's coming from their side, from the employers and the HSE and the government, isn't backed up by evidence. But there is evidence to back up the case, and there's some law on your side as a worker in a hospital, and in terms of your own health care, your own health, but also in terms of cross-infection with patients. So I think you just have to work with your colleagues, work through your union, and make that case again and again.
Thank you. Andy, would you like to finally make a final comments? Any final comments? No?
No final comments, no. Great, yeah, great stuff, yeah.
Okay, thank you very much. And just a couple of points on what Don's contribution is. It seems a nonsense that we talk about lifts only holding one person, where there's no windows or anything in it, and then you've got offices where there's no windows and we have 5 people in it. I mean, that just makes an absolute nonsense of that.
It's illogical.
Yes, absolutely. And also about shield, people have been shielding. Even the guidance talks about enhanced risk assessments. It talks about, a proper risk assessment in stricter controls of all the risks. And we need to make sure that employers are doing that, because we've been contacted by other reps about employers that are not doing that. They're not looking at the risks in terms of enhanced risks that people are facing. And it's really important that employers start to control those risks and the enhanced risks that individuals are having to face. So we're coming to the end of the evening, but thanks very much for all your contribution, and thanks to the speakers, and hopefully that's given you some information and some important important information that you can take back into your workplaces. And it is important that we have a safe return to any workplace, and that's going to be essential, as I think was said before, that it's essential for the economy, but it's absolutely essential for our communities. And if we don't have safe returns, then we're going to see the transmission rate go massive. And it's got to be our, safety in workplaces, as Hilda's talked about, is about looking at the risks and controlling those risks. And that's no different now than what it always has been. But the transmission risk of the virus is greater. And all the information about the aerosols spread and airborne route of the virus is really critical now, because that's what's being overlooked because of the need to get people back to work. And when you're looking at that, then it's going to cost more money. They need more resources in workplaces, and actually we need less people in workplaces at the moment. And that's more resources, perhaps in better, in more buildings, and so we can spread out people a bit more. But also about, what ventilations is existing in the workplaces as well. So hopefully you'll find that you can take some of that information back, but also I think absolutely the point that Tracy made about us doing a campaign within the hazards campaign to make sure that trade unions are taking up these issues, and to also make sure that we're all campaigning together on those issues, which are really critical, I think, to people's safety and health in the future. So once again, so thanks very much for all your participation, all your questions and your contributions, but especially to the speakers, and we hope to be working more with Doctors in Unite in the hazards campaign in the future. So thank you very much, and you can unmute yourselves.
Aye.
Thanks, everybody.
Thank you very much.
Thank
Bye.
you. It was great. Thank you.